Why is it that on average, new immigrants' health is worse off than that of Canadians? New Canadian Media spoke to Dr. Usha George, Dean of Ryerson University's Faculty of Social Work and one of the members of the Immigrant and Racialized Women's Health Project. Her team reviewed academic literature and presented it to community members and activists at their annual meeting at Ryerson on February 21st.
Much of what we did in the last 2-3 years is what is called not only the literature review, but we summarize the literature and then do what is called knowledge translation forums, where we invite community members and people of all types who are interested in health issues to come and attend sessions where we talk to them about the findings from the literature in simple language, so that there's no professional jargon involved and people can understand it better. The purpose is that we believe that health literacy, that is knowing much more about health issues, will enable people to manage their health better. Minority populations have less access to health, less outcomes, and then they have more diseases, and severity of the diseases themselves are also very high compared to the normal population. It is interesting and in some way contradictory, because when immigrants arrive in Canada, we call it the healthy immigrant effect, which is basically saying, or immigrants saying they're having good health. In other words, their health status is seen as good. Over 4 or 5 years of being in Canada, or even much later, that being good health status kind of declines 1 or 2 points to modest health. Why is it happening? It's mainly lifestyle changes and people not knowing, and lack of understanding about the system itself, and access to health care, and even the quality of health care they receive. First of all, more and more evidence is there to show that many new immigrants do not have family doctors. Even if they do have family doctors, sometimes the family doctors themselves can kind of decide on one treatment or the other, or not to provide, preventive mechanisms. For example, it must be about 10 years ago, or even before that, I, along with a number of my colleagues at University of Toronto, did a study on mammograms and immigrant women, and we found that family doctors were reluctant to prescribe mammograms for immigrant women, simply because they thought that they will not go anyway, why prescribe? But the family doctors, in my opinion, are key to this. Family doctors are key to understanding or navigating the system, because when you go to a family doctor with an issue, the doctor would say, okay, I'll get an appointment for you with so and so and so and so and so on. So it is they who are the gatekeepers who move you to specialists. It can also happen then that by the time the specialist is able to see the individual, her or his health condition would have deteriorated. Especially if you have multiple problems, it takes a lot of time to kind of go through all of that, and add to that somebody who has to take leave from work in order to take you to the doctor, somebody who has to understand the terminology that is even being used by the doctor, and then the system where your information about a patient is not shared with his family or his, his counterpart, so to speak, or a partner. All of those are issues.
And do you think the family doctor setup that we have here, do you think that's effective? Like, do you think they're able to do a good job of directing people?
Some of them are very good, I would say. Some of them are very good. But some of them are probably, they're too busy. They are seeing too many patients. So, yeah. So there is a shortage of family doctors here, right? Disparity exists for both men and women. But women, it is much more so, simply because you find more women dependent on their family members to go to hospital and so on. There may be language issues. many women who are coming in are at the childbearing age, and many of them may have children. So, and a great number of them would stay home to take care of the children simply because they can't afford the kind of childcare that's, which is very expensive. By that very phenomenon, many immigrant women get isolated from, the sort of the general public. Things may be changing now, but nobody keeps track of how much it is changing. So still the story about not understanding, the language, not understanding the culture, not understanding the environment, and not understanding some of the health care activities that they need to take or precautions they need to take. They don't know. For example, look at the food. Most of the women who came from, developing countries literally cooked their food for every meal, fresh food from the farms or wherever. Here we come and we get used to all kinds of ready-made food and fast food, and not recognizing the impact it can have on health status.
Diabetes, for example, is considered a disease of the West, a disease of affluence, but here in urban Toronto, when we're talking about risk factors for diabetes, it's very much about poverty and lack of food security.
They may be, again, not understanding the system that can exist. And immigrant women are also more prone to be living in poverty than immigrant men. That's what they talk about. So many of these kind of access issues, or unequal access, or the existence of health inequality or inequity, are based on sort of social and environmental factors. Are you employed? Are you not employed? Do you have good housing? Not good housing? Or how much do you understand the system? How much do the providers understand you as an individual? All of this is part and parcel of an immigrant woman's living reality.
For New Canadian Media, my name is Maria Asaf.